you very much. I'm delighted to talk about this. I thought, wow, how to do this in 10 minutes. I'm at 9:54, and I won't be like, hitting you with a bunch of slides, but I really want to reiterate some take-home points, and let's start thinking about the physiology a little bit about this. So, why do we care about women's cardiovascular risk? Because it's the leading cause of death in women. And in 2019, 301,000 women succumbed to cardiovascular disease. Women are susceptible to stroke and are more likely to die from it. And, we have traditional risk factors, and I'm not going to talk about those today. But again, it's really obvious when we think of modifiable risk factors. I know there was a morning session on hypertension. That's like the low-hanging fruit. But moving on, we need to really be very diligent in how we interview our female patients. I am from the Midwest and recently moved to the South, and every time I look at the CDC map, it just makes me pause because we do have some disparities in cardiovascular mortality for women over the age of 35. Since this is a kind of a Georgia-California chapter, I think it's impressive to see really along the coast of California, you see fairly low mortality rates for women. When we look at Georgia, we can see some, very impressive areas, which speaks to a lot of work that we need to do in social determinants of health for women. As a member of the AHA as well, we've had Go Red. We've done, I think, pretty exhaustive work to make women aware that they're more likely to die of cardiovascular disease than they are of cancer. And yet, a recent update a few years ago from Dr. Barry Mayers shows we're kind of going backwards. And so less women, especially younger women, they don't recognize the need to modify cardiovascular risk. So let's talk about cardiovascular risk factors related to pregnancy. And I kind of lumped it into sex hormones because when we talk about infertility, we're going to talk about PCOS, we're going to talk about early menopause. There are some potential progesterone and endometrial-related infertility that have kind of there isn't a lot of great data about cardiovascular risk, but it's in there. But the well-known ones that we've started to pound on, I think, from a PR standpoint, are really preeclampsia and gestational disorders, as well as preterm birth. So let's talk about mechanisms. I drew the. Okay, so I drew this because, everyone's like, oh, preeclampsia, but really, this is kind of on a spectrum, and we need to look at these placental disorders as being on a spectrum of severity. Preterm birth oftentimes just suggests that you had an insufficient placental perfusion, you had intrauterine growth restriction. And that's because really the placenta is very sensitive to a lot of the insults that occur systemically, right? That's not surprising. So if you have hyperlipidemia, hyperglycemia, obviously we would see this during gestational diabetes. In hypertension, you can generate obviously free radicals, hypoxia. And so you have a state of placental ischemia and hypoperfusion, which is manifested by, one, alterations in nitric oxide signaling, which is what I'm interested in. And we've tested this. I've actually performed pressure myography on the placental vessels, so not spiral arteries, because that would be on the maternal side, but really on the placental vessels, and they have significantly impaired acetylcholine-induced vasodilation in those placentas that come from women who have a diagnosis of preeclampsia. On the other hand, if you treat those same vessels with acetylcholine-independent NO mechanisms, you can get robust vasodilation. So there really is a pretty well-described endothelial dysfunction. We're obviously well aware, or maybe not, but you can see reductions in VEGF. There's soluble VEGF receptors that are scavenging VEGF. And so what you end up with is impaired remodeling, which is necessary to expand perfusion within the placenta. You have impaired trophoblast migration and placentation. And what you end up having is a failure for the spiral arteries to remodel and be able to provide conduit blood flow, which is kind of a positive feedback of ischemia. So this is kind of the global view of this. And again, I'd like you to think of all of these on a spectrum, and preeclampsia is the most severe. And it also explains probably why, we were always under the impression, deliver preeclampsia, the symptoms go away, but now as we've done longitudinal studies, we know, one, their cardiovascular disease is much greater. So we know that preeclampsia carries a nearly fourfold risk for hypertension, into the second decade after pregnancy, and a doubling of their risk for heart disease and stroke. The earlier onset of preeclampsia, and therefore the earlier gestation and delivery, is associated with poorer outcomes, and that makes sense based off of the physiology, right? If the placenta can't handle its environment and it's failing, the pregnancy isn't going to last. And again, we kind of touched on this, and I won't go into too much detail, but it also helps us for talking about infertility. We are well aware of microvascular dysfunction, which is, again, a systemic and multi-organ disease. That's what I'm calling it. It's obviously the relate of reactive oxygen species, but we know that estrogens do increase nitric oxide-mediated vasodilation and can affect these arterioles. When you have areas of diseases like PCOS, where you have hyperandrogenism and early onset menopause, you can essentially blunt or attenuate some of the estrogen and NO-related mechanisms. See, it's hard, I'm at 2:44, but I'm almost done, I promise you. So we've been able to see this now in population data, and I really want to shout out to Aaron Mikos, who started to really start to tease this out, because for a long time there was really kind of a debate as to whether PCOS and PCOS-related infertility is a cardiovascular risk. But the Danish registry showed there was a significant number of cardiovascular events in women who had PCOS as defined with hyperandrogenism. And in Australia, there was a retrospective study as well. If you look at hazard ratios in general, you can see nearly a 2 to 3-fold increase in heart disease, cerebrovascular disease, and PE. And also there are some other meta-analyses. And again, we're talking about in PCOS, we have, again, a metabolic phenotype, which portends a poor basically a poor vascular function. One thing I wanted to point out is we're always focused on cardiovascular risk in the setting of coronary or vascular disease, but it really should be impressed upon you that HFpEF and infertility have also made an association, and this was published last year in JACC using the Women's Health Initiative data that looked at those women who either had irregular menses or had premature menopause had a higher likelihood of developing HFpEF. Again, probably a microvascular component. So, when should you refer your patients to see a women's cardiovascular specialist? I'm pleased at the number of programs that are starting to develop. We have one, I know there's many in Georgia and California, but if you interview your patient and they've had a history of adverse outcomes in pregnancy, this is definitely where you want to be on a higher alert to more aggressively manage their cardiovascular risk. Obviously, gestational hypertension and diabetes also is, again, kind of it falls in that category, as well as just carrying a diagnosis of hypertension and diabetes. Obviously, an infertility diagnosis with PCOS. I didn't get into the dyslipidemia related to that disease. And also those that want to kind of learn more about the timing of hormone therapy during menopause. So, to summarize, take a thorough history. So whenever you see a woman, irrespective of her age, you need to ask for the age of onset of menarche. You need to know how many pregnancies she's had, if she's lost any pregnancies, why, and when during gestation. And you need to understand if that was a full-term healthy pregnancy without complications. I didn't stress during PCOS, but there's a fair amount of outcomes data around the timing. The inpatient patient sample actually showed that women who have PCOS and are fertile, which is more common than you think, actually have higher risk of peripartum cardiomyopathy. No matter what, continue to use the ACC pooled cohort risk calculator, and obviously empower your patients to seek cardiovascular care immediately. So thank you very much.